Hello, I'm Peter Lawrence, Senior Editor of the Journal of Vascular Surgery. I'd like to tell you about the December issue of the JVS, which has another outstanding lineup of papers. An important paper on acute, uncomplicated type B aortic dissection by Ray and colleagues from the University of Texas, Houston, retrospectively looked at 150 patients who had serial CT scans to determine the initial characteristics of dissections that ultimately required intervention over a 10-year span. When the maximum aortic diameter exceeded 4.4 centimeters, and when the false lumen was greater than 22 millimeters, there was an increased need to intervene, and this risk increased from 19 to 30 and then 50% over 1, 5, and 10 years respectively. Although this study was retrospective, it suggests that large aortas and those with large false lumens should be considered for early endovascular treatment. Obviously, there now needs to be a prospective study to determine if early interventions will actually reduce mortality in this group of patients. The next paper, Dual Antiplatelet Therapy is associated with prolonged survival after lower extremity revascularization, by Soden and colleagues, used the Vascular Quality Initiative dataset and analyzed the impact of a single antiplatelet versus dual antiplatelet therapy on the survival in 50,000 patients, 30% of whom had open bypass and 70% of whom had an endovascular procedure. Endovascular procedures and open bypasses were performed for both critical limb ischemia and claudication. The authors found that there was a slight but statistically significant survival advantage early and at 5 years when dual antiplatelet therapy, rather than single antiplatelet therapy, was used, presumably due to a reduction in coronary events. Since the advantage of dual therapy is so slight, subgroups with bleeding risk will need to be analyzed to determine if the advantage of dual therapy exceeds the occasional risk of increased bleeding. The CME paper for this month is by Davila and co-authors from Mayo Clinic, where the Shamblin classification of carotid body tumors originated, and is entitled Current Surgical Management of Carotid Body Tumors. They report on their large experience managing 186 patients with carotid body tumors over 20 years. CT scanning and MRI were the most commonly used diagnostic studies, and angiography was performed in 40% prior to surgery to embolize the tumor and to reduce bleeding. The Mayo Clinic group had a very low mortality and stroke rate and rarely needed to reconstruct the carotid artery, although the cranial nerve injury rate was significant at 6%. Although carotid body tumor malignancy was rare in their patients, they recommend genetic testing for succinate dehydrogenase gene in young carotid body tumor patients, since it helps to identify relatives with carotid body tumors and other paragangliomas, as well as bilaterality. The last paper highlighted this month amputation trends for patients with lower extremity ulcers due to diabetes and peripheral artery disease using statewide data as by Humphreys from UC Davis and colleagues. She analyzed trends in amputation among patients with foot ulcers and found that those patients with a combination of diabetes and PAD have a significantly increased risk of amputation, which increases with increasing hospital admissions, ER admissions, and clinic visits for foot ulcers. The authors have identified a subgroup of patients with PAD and diabetes who are seen more frequently in these settings and may be managed more effectively to prevent amputation. This is just a sampling of the many excellent papers in the December issue of the Journal of Vascular Surgery, which you have the opportunity to read as you enjoy the holiday season. Have a happy holiday, and we look forward to seeing you in January. Thank you.